So in the first session, we discussed about cross-sectional study, how to calculate sample size in cross-sectional study. And in this today's session, we'll discuss briefly about how to calculate sample size and what are the sample size issues if you are planning a case control study. So we will not go into the detail of the methodology of the case control, like how it is different from cohort or from cross-section, but we will try to focus the entire session basically on the issues related to the sample size in the case control study. So with that, I will start the session, although there are 86 participants, but since the recording of this session will be available to you, including the presentation. So without wasting the time, I will share my screen. So is the screen visible to the participant? One of you can type in the chat box. Is it visible? Or Richa, Venkatesh?
Yes, ma'am, it's visible.
Okay, thank you. So today we'll discuss the case control study design. So again, like the previous session, this session also, it is interactive. So do type your response in the chat box. So the first thing that this question is to all of you, that there is a hypothesis that I have made a hypothesis that, neonatal jaundice, does it affect the IQ, that is the intelligent quotient in childhood or not? So if I am having this hypothesis and I want to test this hypothesis, and for this I'm planning to do a case control study, or there are various ways to test this. You've got three options. You can have a case control, you can have a cross-sectional, or you can have a cohort also. So in this case, just see this example. So you retrieve the medical record of all children who are born in year 2016. And then what you do, you divide those children into two groups. So jaundice present and jaundice absent. And then what you do, you measure their intelligent quotient or IQ level, and you categorize them as a normal, low IQ or normal IQ. So which type of study design it is? Since I am guessing that all of you have some knowledge about the study design issue. So with that, your previous knowledge, do respond this question. First, tell me what is the exposure here, because in all these study design, we always talk of exposure and outcome. So exposure is something which we describe in terms of the risk factor, and outcome is something which we describe in terms of maybe disease in this case, or some positive outcome. So in this case, outcome is the IQ and the risk factor or the exposure is the jaundice. So yes, you are right. But what type of study design it is? If I'm starting with the jaundice and I'm measuring the IQ. So is it a case control study design? Is this study is a case control? Just type yes or no. So the answer to this question should be in the yes or no. So there are mixed sort of responses, both yes or no. But in this case, if you have categorized the exposure as a neonatal jaundice and outcome as an IQ, then definitely you are measuring the outcome later and you have started with the exposure. So this is a cohort study. In this case, that means that the answer to this question should be no, because you are starting with the exposure and then you are measuring the outcome. So be careful in your mind. Any research question, try to dissect the two component, that is the exposure and the outcome. And if you're successful in dissecting your research question into exposure and outcome, then things become very easy. So yes, answer to this question will be no. Now see this question. So again, the same question, you measure, the research question is same, but in this case, how you have proceeded, let's see this. So you have measured the IQ level of children and categorized them as low IQ and normal IQ. And then you retrieve the medical record of all children for birth history. And then you looked for the presence of jaundice or absence of neonatal jaundice. In this case, is this study is a case control study? Please type yes or no in the chat box. So yes, I can see, I think most of you, I think all, rather, there's no answer which is No. So now all of you are clear what is a case control study and how we are starting with the cases, having a control, and then going back and see the exposure. So that's the classical case control study. There are variants of case control study, which we are not discussing here, but this is a classical case control study. So in a classical case control study, you have the cases with you, and then you see the level of exposure and not exposed in that cases, and you take the controls also, and again you measure the exposure in the controls, and then you calculate the odds ratio or you do the measure of association. So a case control study, always remember, it starts with the cases. So you have to select the cases first. So that's why all the sample size, wherever you will calculate the formula, that says about the cases. And then the controls, it can vary. And we will see how the ratio of cases to control can vary depending upon the resources, depending upon the availability of time, etc. So in case control study, we always start with the case first, and then we select the controls. And like many times in medical science, it is not possible to conduct a clinical trial. So when this case control study is warranted, because the clinical trial, again, you need to register, you need a lot of resources, you need a follow-up time, or for a cohort study also, we know that if the disease takes a lot longer time to develop, then again we may not be having that much time to measure that outcome with that exposure. So in that case, when the disease is very rare and it will take a long time of follow-up, in that case also it is undesirable to do a case cohort study or a randomized control trial. In that case, like just see this example. If you want to see the association between the high fat diet and cancer, so I want to test this hypothesis. So I have got three options. I can do a case control study, I can do a cohort, I can do a randomized control trial. But RCT, since although the evidence is high, but because of the ethical concern, I cannot expose a person to a high fat diet and see whether the cancer develops or not. So because of many times there is if that exposure is a risk factor, you cannot, because of the ethical concern, you cannot do a randomized control trial. And cohort also, if you know that, the disease will take long time to develop with that exposure, then also you don't want to do a cohort study. Or the second research question could be, if you want to see the association between the childhood sexual abuse and psychiatric disorder in adulthood. In this case also, you will see that it is not possible to do a cohort study or to do a randomized control trial. In that case, case control study is a very good option, although it has got its limitation, but with the selection of appropriate control, you can remove those limitations. So these are the two examples where we have shown you, followed by this third example, where we want to test the association between the colorectal cancer and prior antibiotic prescription. So maybe the exposure in this case is the prior antibiotic prescription and the outcome is the colorectal cancer. Again, it is difficult to test this hypothesis with the cohort study or with the randomized control trial. So case control study is an ideal type of study design in such cases. So you should always remember that this is an alternative to a clinical trial or a cohort study. Although if you see the level of evidence, we all know that it lies, the cohort and randomized control trial are much above the case control in terms of the quantification of level of evidence. So level of evidence is definitely low, but again, to have a, start with some hypothesis or to do it in a short span of time, or to if you have less resources also, then also you can plan for a case control study. And again, there are variant of case control study, like nested case control, or there is a case cohort study, when you can reduce these biases and you can increase the level of evidence. So that's how a case control study, it's a very useful way to test for a hypothesis. And again, there is another option, the retrospective cohort also, which is also a good option, where you start with the exposure, but that is a record based, and then you follow that person up. So that retrospective cohort, we will discuss that this type of cohort in the next month session, which is on the cohort study. So today we are limiting ourselves to the case control study. So in retrospective, again, you require a good database. For case control also, generally, you will see classically in all the literature, if you search the literature for a good case control study, it is usually, all these cases, it's a record based. And the exposure also many a times it can be record based, or it may be basis of the interview. But again, if you are taking the interview, it is prone for we always discuss this, that it is prone for the recall bias, because the cases, they will try to remember that exposure very, very tremendously as compared to the controls. So that's why it is prone for recall bias. But if you have the records for exposure of the controls and cases, then you can reduce this bias also. So again, a good record is needed to have a good, either the retrospective cohort or a case control study, because most of the cases, what you study, especially the cases, that will be record based. And then control, you can have a record based, or you can interview people and you can select. You can have more than one type of control also, like you can have a hospital control, or you can have one control which is the hospital one, and the another control you can have a community based control, because we know that there are limitations of hospital based control. So it is always good to have a community based control to have a true picture of the exposure, distribution of exposure in the control. We will discuss all these factors subsequently, but to have a good case control study, or to plan for a good this retrospective cohort, there should be a good pre-existing database. And unfortunately, in our hospital setup, or in our, it's not, everything is not digitalized. And, there are many missed records also. You must have seen in your institution, whether it is a digital record or whether it is a hard copy paper-based record, you will always find that there will be many records which are not complete. So again, that is a limitation, but within that limitation also, there are many methods also by which you can reduce these biases. So now the measure of association in a case control study is the odds ratio. So now you have to respond to these questions. So in this question, what is the odds of cardiovascular disease? So CVD, you can see a 2x2 contingency table. The column shows the cardiovascular disease status, presence and absence, and the gender is the male or female. So the question is, what is the odds of cardiovascular disease present in male? So what is the response? It is 9. So it's the odds. I'm not asking odds ratio. Everyone is answering in terms of 9 or 3. No, you have to answer in terms of odds. I'm not asking right now the odds ratio. What is the odds of cardiovascular disease in male? So yes, it is. You please write in form of the formula. Don't give the final answer, because then it will be easy for the participant to understand. So yes, Ria is right. It is 6/2. So odds of cardiovascular disease. So how do we define odds? Odds we define as the presence of that disease, and in denominator we take the absence of that disease in a particular gender. Like in this case, it is the 6 men out of total 8. So the odds of the disease in male will be 6/2. Similarly, if the next question is the odds of cardiovascular disease in female, then what will be the odds? In this case, please write in the chat box. Yes, so now you got it right. It is the 1/3. So before you calculate odds ratio, first try calculating odds, because definitely the odds ratio will be the odds of disease in male and odds of disease in female. So yes, you are right, it is 1/3. Now if I ask this question, the odds of disease is how many times in male in reference to female? then what will be your answer? Yes. So in this case, it is 9 times. Or if you write like, 6 by 2 divided by 1 by 3. So yes, the overall answer will be 9, but don't try doing AD by BC. Yes, don't try doing AD by BC because odds is in reference to something else. So in this case, if I reverse the question, if I ask like what is the odds of presence of CVD, means I'm asking the odds ratio in female as compared to male. So the question will be the odds of presence of cardiovascular diseases, how many times in female in reference to male. Then what will be the question? Yes. So yes, Ria is right. Anyone? 1 by 3. Yes. And 6 by 2. Yes, you are right. So now it is reversed. So you try explaining this, like 1 by 3 and 6 by 2. Ultimately, it will give the odds ratio in female. So now what is the concept of this odds ratio versus risk ratio? We will understand this by simple example, how this odds ratio is different to the risk ratio. So let's see the relationship between these two. So first scenario is when the cases are not common. That means that disease is not very common. So now what will happen? So now they see this thing. There is a presence of disease and there is an absence of disease. And you can see the exposure and outcome. So in this case, this is a 2 by 2 table and you can see the distribution 10, 40, 2 and 48. So now you see, you have to answer these questions. So first is odds of exposure among disease. What is the odds of exposure among disease? Okay. Yes. Odds of exposure among the disease. So you have to write 1 by 4. No. Yes. Tanya is right. Odds of exposure among disease. So out of total 12 people, exposed are 10. So it will be 10 by 2. Is it right? And then the next question, odds of exposure among non-diseased. Odds of exposure among non-diseases? Yes, it is 40 by 48. No, you have to write, see this carefully, odds of exposure among non-diseased. So you have to write, yes, Varun, Pankaj, these are the right answer. It is 40 by 48. Are you people clear? Now see, you have to see the vertical, focus on the vertical. The question is odds of exposure among disease. So you have to see the disease column. So the disease is 10 in the exposed one and the disease is 2 in the non-exposed one. So the odds of exposure, see, before I ask these questions, I will make you clear. I will make it clear that the odds ratio is of two types. There is a disease odds ratio and there is an exposure odds ratio. Disease odds ratio is the odds of disease in the exposed individual. And exposure odds ratio is the odds of exposure in the diseased one. Okay. So disease odds ratio, generally, we can talk of both the things in case of a case control study. And I'll show you that actually the both are same. How we will see it. Because the case control and cohort, classically, we see that there is a difference in direction. So first answer these questions and then we will understand. So do you understand now the odds of exposure among non-diseased? So this is the non-diseased column. Everybody is clear on this. So odds of disease, odds of exposure in non-disease will be 40 by 48. And if you calculate the odds ratio, what will be the odds ratio? Yes, it is 10 by 2 divided by 40 by 48. Yes, Vijna, Sanjay, you people are right because I am seeing it on screen. So this is very much right that this will be the exposure odds ratio because I am now measuring the odds of exposure among the disease. Now with this 2 by 2 table only, I can calculate the disease odds ratio also. Now answer this question. What is the odds of disease among exposed? Please, all of you type in the chat box. Okay, Tanya is writing. Shruti. Yes, it is either 10 by 4 or 1 by 4. It is right. Now the second question. What is the odds of disease among non-exposed? So it is 2 by 48. Yes. Now you calculate the odds ratio. What will be the odds ratio? Yes, what will be the disease odds ratio? Yes. So if you calculate it, you will see that mathematically or numerically, these two are same. It is 6.25. You can do it. It will be 6.25. So what do you understand by these two examples? That in a 2 by 2 table, the disease odds ratio and the exposure odds ratio, they both are same. The numerical value of both the disease odds ratio and the exposure odds ratio is same. Now you calculate the risk, because we are going to understand the difference between the concept of odds and the concept of risk. Now please calculate the risk of disease among exposed. Yes, Vijna is writing, Shruti, Gaurav, Kumar. So you are right, it will be 10 by 50 because in denominator, you take the whole 50. So it will be 10 by 50. Now, in this case, if you want to calculate the risk of disease among non-exposed, how you are going to do it? So I'm sorry, I've shown you the answer before I saw your, so your answer would be 2 by 50. Yes. So do you understand the exposure and the odds and risk? What is the difference between the odds and risk? In risk, you take the whole denominator, whereas in odds, you don't take the denominator. And if I ask you what is the difference, what is the risk ratio in this case, then what will be the answer? Please calculate the risk ratio. Yes, it will be 10 by 50 divided by 2 by 50. Yes. And the numerical value will be 5. So you can see here that both the disease odds ratio and the exposure odds ratio is same, but the risk is different. And this is when the disease is, you can see that disease is not very rare, then this happens. Now see another question. In this case, what we have done, in the last scene, you can see here the number of cases. So I have fixed the number of cases here in the second example, but I have doubled the control. So in this case, you can take it as a case and control. So there are 12 cases and there are 88 control here. And I have just doubled this control. You can see there are 80 and 96 controls. So now you have to calculate. So please calculate the odds of exposure among diseased. Please type in the chat box. Odds of exposure among diseased. 10 by 2. It won't be 10 by 80. 10 by 80 will be the odds of diseased in exposed one. So here the correct answer would be 10 by 2. Odds of exposure among the diseased. The second is, what will be the odds of exposure among non-diseased? Please type your answer. Yes, right. It is 80 by 96. Now, what will be the exposure odds ratio? Please do it. You can calculate it in the, maybe you can write it formula wise. So it is 6.25. So remember, in the previous example also, what was the exposure odds ratio? If I go back to the previous slide, the exposure odds ratio and the disease odds ratio both was 6.5. And in the second example, what I did, I have doubled the cases will be the same, but I have doubled the control. So in this case also, second one, you can see that the exposure odds ratio is 6.25, same as the previous one, because I have fixed the number of cases. The only thing which I did, I have doubled the number of control in the same strata, in the exposure presence and exposure absent, means the distribution of that exposure factor is same in the control, that I have not changed. So that's why you can see that the odds will be same. Now, what will be the odds of disease among exposed? Please type in the chat box. Odds of disease among exposed. Yes, Gaurav, Nilima, Prem, Sanjeev, Srijan, Dhananya. Yes, you are right. It is 10/80. And what will be the odds of disease among non-exposed? Yes. So Srijan, Vijna, Tanya, Premal, all of you are right. It is 2/96. And what will be the disease odds ratio? So if you calculate the disease odds ratio, numerically it will be same, the 6.25. So again, we can see that the exposure odds ratio and disease odds ratio, although we calculate it like we calculate the disease odds ratio in horizontally, and we calculate the exposure odds ratio vertically, but numerically these two are same. Now let's see this with the risk. So what is the risk of disease among exposed? Please write it in the chat box. Risk of disease among exposed. So yes, it will be 10/90. And what will be the risk of disease among non-exposed? We have just talked that we calculate it in the horizontally, the risk of disease, because you have to see the exposure and you have to see in the non-exposed. So yes, it will be 2/98. It will not be 2/96, because 2/96 will be the odds. If you have to calculate the risk, you have to take the whole denominator. So it will be 2/98. And if you calculate the risk ratio, in this case, the risk ratio is 5.5, which is different from the previous one. Now see this third example. In this example, I have again did it 10 times. So this disease I have taken 10 times than the previous one. In this case also, what is the odds of exposure among disease? Yes, please write it in the chat box. Odds of exposure is 10/2. Yes. And what is the odds of exposure among non-diseased? It is 400/480. Yes. And what is the exposure odds ratio? Again, it will be the same. So it will be 6.25. And now if I want to calculate the odds of disease among exposed, then similarly, like we did previously, it will be the 10/400. The odds of disease among non-exposed will be the 2/480. And the odds disease odds ratio will be 6.25. And if I want to calculate the risk among exposed, on the similar thing which we discussed with the two example, it will be 10/410. Yes, you are right. Risk of disease among non-exposed will be the 2/482. And then the risk ratio will be 6. So now you can see that risk ratio is increasing. Initially it was 5, then 5.5, then 6. And that will show you that with increase, that's how, by this example, what I want to emphasize. I want to emphasize three things here. The first one, disease odds ratio and exposure odds ratio is same numerically. First thing. The second thing which I want to emphasize, that is, if you increase the number of control, maintaining the same level of exposure, then also the odds ratio doesn't change, but the risk ratio, it changed. That's why in a 2/2 table, if someone says, no, I will measure the risk in case control, someone can say, because he will say that, it is the 2/2 table. I can measure the risk also in 2/2 table. Why I can't measure the risk in 2/2 table? So the answer will be that risk will keep on changing with the increasing number of control. But if the exposure level is same, your odds ratio will not change. That's why risk is not a good measure in the case control study because you don't have a denominator, and that denominator is not the representative of the population. If you plan a case control study where you take all the population as a control, and then in that case you take the cases, in that case your relative risk and odds ratio will be the same. Because no, sorry, in that case that is again another situation, but in that case it will be a true representative. Your risk which you calculate from a 2x2 table, that will be the actual risk. Now I again made a statement when numerically this odds ratio and relative risk is same, and that we are going to see. So there is a relationship between the odds ratio and relative risk when the disease is very common. So in this case, this has increased. This is you can see that the previous example, the disease was less, but here I have increased the number of disease. So in this case, you can see the number of disease are 350 as compared to the controls. Almost they are, we can say they are comparable. So now can you calculate what is the odds of exposure among disease in this case? So it will be 300 by 50. And then what will be the odds of exposure among non-diseased? In this case, it will be 200 by 450. And if you calculate the exposure odds ratio, it will be 13.6. So in this case, how this example is different from the previous one? Because in this example, I have increased the number of cases. So when the disease is common, the first example, the disease was not that common. But in this case, you will see that the disease is very common, and there is a distribution of the exposure is almost same. In this case, again, if you see the odds of disease among exposed, then it will be 300 by 200. Odds of disease among non-exposed will be 50 by 450 like we did for the previous one, and the disease odds ratio will be the 13.6. So both these are same. But in this case, if you see the risk, then the risk of disease among exposed will be 300 by 500. Risk of disease in non-exposed will be 50 by 500, and the risk ratio will be 6. So this is a first example. So you can see here that there is a difference between the odds ratio and relative risk. And in this case, the risk ratio is approximately half of the odds ratio. Now see this example again. Here I have increased the previous example. You can see the disease was 200 and 450. The control, I have increased the controls to 10 times. And now you see the odds of exposure among the disease. So odds of exposure is again 300 by 50. Yes, you are right. Odds of exposure among non-disease is 2000 by 4500, and the odds ratio is 13.6. So it is same because I'm increasing the control with the same proportion of exposed and non-exposed. So the exposure odds ratio and the disease odds ratio will be the same in this case also. Now, the most important in this case is the risk. So if you see the risk, it will be 300 by 2300 in the exposed, and it will be 50 by 4550 in the non-exposed. And if you see the risk ratio, it will be 12. So you can see the more you increase the sample of the control, this will be the approximation. So in this case, what I want to emphasize by these examples, that the control should reflect the exposure pattern of the source population. So that's why in case control study, the selection of control is the toughest part. If you select a control where the exposure distribution is not that of the source population, then you are never going to get a true association between the exposure and the disease. So if the source population has exposure to a non-exposure proportion in 1:3, then the control should also reflect the same exposure pattern. That's why we say that community-based control are always good, because they reflect the true status of the exposure. So this is the basic assumption of the case control study, and that should be kept in mind whenever you try selecting controls. Because controls, selection of control is the toughest decision in the case control study. From where to select? Because from where you will select, that will show classically the difference in the association. So in this case, like just to emphasize this example, in the population, if the ratio between the exposed and non-exposed is 3:7, like 300 are exposed and 700 are not exposed. So control, wherever you select the control, it should have the same population, distribution of the same exposure in the controls also. So then it will give you the correct measure of association, and that odds ratio will be the correct odds ratio. So if you can assume that the distribution of exposure in the control group, it entirely represents the distribution of exposure in the population, in that case, the disease odds ratio and the relative risk, it will be nearly same. So now this was some basics of case control study. Now coming to the calculation of sample size. So whenever we calculate a sample size for a case control study, we need these input to put in the software. So you need the odds ratio of the study. You need the proportion of the population exposed to the risk factor of interest. You need the level, like we talked about the level of significance and power in the first session. So you need at what level you classify it to be statistically significant. And also you need the required power of study. So that minimum significance we fix at the 5% and the power minimum we fix at the 80%. So that we discussed in the first session. So I'm not going into the detail of that. Here we will discuss mostly the odds ratio and how this change in the odds ratio or change in the exposure pattern in the population affects the sample size. So the assumption which we will be testing in the statulator, mostly in case of a case control study, the outcome is in the form of a binomial distribution. That means something is present or something is absent. So we have to see the outcome present or absent. And again, we see the exposure present or absent. So we compare the two proportion. So you should have either the odds ratio, and the proportion in the exposed or non-exposed. You should have the alpha level and bar. And adjustment, it depends on you, whether you want to adjust it for the, we have seen that adjustment can be made with the ratio of cases to control. It can be made if you are taking a cluster sampling, or it can be if you want to increase the power or reduce the significance. In that case, also you can adjust. But again, if you want to compare two means, although comparison of mean in case control study is not a very common thing which is done, but we will discuss when we can do a comparison of mean in case of a case control study. So you can use, if you want to compare the mean as an exposure, because remember, in case control study, you are measuring exposure. So whatever we are talking here, we are talking about the exposure pattern in the disease and in the non-diseased one. That means in the cases and in the control. So if you are asking, if you're talking about the mean, then you have to see the input as whether the mean difference between the two levels are there or not, or standard and standard deviation. So that should be the input which is minimum. And again, that alpha and power that you fix, whether you want to keep it as 5%, 3%, 1%, or power, the minimum you start with 80%, you can increase it to 90, 95, etc. And design effect response rate, if it is required, then you can adjust it. If it is not, then it is up to you. So now there are various determinants of sample size. So the first determinant of a sample size is the most important, that is the risk factors. What are the risk factors? Or if you are seeing any intervention under the study, then what are those? Then what is the distribution of that risk factor or intervention in the population? What is the power and statistical significance of the study? What should be the case and control ratio? And how do we take the effect of the confounding factor in the sample size? I'm not discussing in general what is confounding factor. How do you adjust for confounding factor in the calculation of sample size? And how do you control for the matching? So I will discuss the first, that was the risk factor or the intervention under study. So if if there is a small association, so we will talk in terms of the odds ratio. So if the odds ratio is small, then you need larger sample size to detect that odds ratio. So that's how we say that the sample size required to detect at the level of 1 point, if there is you are detecting 1.5 and 2, there is a 2 odds ratio. So although the difference of odds ratio is only 0.5, but again, you need at least 3 times larger sample size if your odds ratio is 1.5 instead of 2. And if you focus on this picture, so this has been taken from a WHO reference of a calculation of a sample size for diarrhea. So that is the reference, and we have given that reference in the presentation as well. We will give you. So you can see here, there is a x-axis and there is a y-axis. So the y-axis represents the sample size, that is the number of cases, and the x-axis is the odds ratio. So you can see that with the less than 1.5, the odds ratio is, the number of required sample size is more than 500. So after this 2.5, you can see that there is a decrease in the requirement of sample size. So with this graph, what is the take-home message? The take-home message is, if the odds ratio is 2.5, then, or you can see 2 also, then the sample size is nearly 100, and you can see it is 130 or something like that. But as you go less than 2, then the required sample size is almost 3 times. It is more than 500. So with a change in only 0.5, but that drastic change appears if your this odds ratio falls below 2.5. So this 2.5, you can see it is the, you can see that the change of the curve. Again, just to remember, smaller odds ratio needs very high sample size to test. And that sample size is what I am talking is of cases. Control, it is up to you. You can take 1:1 control, you can take 1:2, or we can go up till 1:4. But I am talking sample size in terms of cases now. Okay. So I hope this concept is clear, that smaller the odds ratio, larger the sample size you require. Larger the odds ratio, and what it does say is that the effect size, the difference in the proportion is small. So to detect a smaller proportion, you need a larger sample size. Okay. So that's why if the odds ratio is less, you need large sample size to test your hypothesis. You can see in this example is also taken from the same WHO study. So in the first case, you can see that there was 2 intervention, improved water supply and unimproved water supply. And these are the cases and controls of diarrhea. You can see the 2:2 table. The odds ratio in this case is 1.5. But the p-value in this case is 0.2, which says that this is not significant. Similarly, there was another study which was done by the poor hygiene. So there is a poor domestic hygiene and a good domestic hygiene. And you can see the distribution of cases and controls here. In this case, the odds ratio is 2. But the value of chi-square and the p-value is 0.025. Okay, because in 2:2 table, we test the significance by the chi-square also. You can have a confidence interval of odds ratio also, but that time, because generally they used to do it with the chi-square. So the value, you can see its significance. So what do I mean by this example? Here you can see the sample size is 200 here also, and the sample size is 200 here also. But in this case, it was not significant, and in this case, it was significant. What do I mean by this? What do you get by this example? Please write in the chat box. So this example actually says that, if the odds ratio is 1.5, it is a less, means the strength of association is less as compared to 2. So in the 200 sample size, your significance will not come. So the moment you see any odds ratio of less than 2, then you should think that the sample size should be more to test that hypothesis. So that's how you can see that with 200 sample size, if the odds ratio is 2, definitely it will be significant. But if the odds ratio is less, you need more sample size if the odds ratio is less. Okay. So I'm only, by this example, I want to emphasize that with the same sample, you have to see the odds ratio. So if the odds ratio is less, then definitely your significance will not come. So if you study, or like many times you draw this 2 by 2 table and you see that the significance has not come. Okay. In that case, you should be thinking in terms of the sample size, that maybe that sample size is too less to prove that to be significant. So if you increase that sample size, definitely it will be significant. Okay. So that's the importance of the odds ratio, the higher and the lower odds ratio. Now, the second one is the distribution of risk factor in the population. So this case, if you see the distribution of risk factor, this is a U-shaped curve. Can you see it? So if the exposure, where it is 50%, what do we mean by 50% of exposure? That in the population is exposed to 50%, means 50% of the controls will be having the exposure and 50% will not have the exposure. In an area where the proportion of population exposed is 10%, less than 10%, or more than 90%, in that case, the sample size requirement will be very high. So the lower sample size will be with the approximately in 40 to 60%, rather the 50%. And if the exposure is less than 10% or more than 90%, it will be, the sample size requirement of cases will be very high. Now coming to the power and statistical significance. So we have discussed, I think, regarding this power and statistical significance in the previous session. So I'm skipping this for now. And now let's start with the calculation of sample size for binary exposure. That means as a categorical variable. So the same statulator we will use like we have seen in the previous session. And here is the example. So before I start with the example, the formula which is running in the background, it is this formula. So the calculation of sample size for a binary proportion, that is the presence or absence of a exposure in a disease and control, it is through this formula. And this, whereas this n is the sample size in the case group. So remember, we calculate the sample size in case group, and then we, according to our convenience, whether we want a ratio of cases to control in 1:2, 1:3, 1:4, depending on the availability of cases. But you don't need to remember or calculate using this formula. This formula is running behind in the statulator. Just for information or knowledge purpose, we have given this formula. Don't get nervous by seeing this long formula. It is just for your knowledge. Just have a look at it. So this R is the ratio of controls to cases. This P is the average proportion. And this 1 minus P is the, if you remove this, if you deduct this from 1 minus P, so this is the multiplication. P into 1 minus P, actually this is the variance. Or in the mean, we'll see this is the SD square. So this whole thing, it represents the measure of variability in the total population. You know about this Z beta. So it is the present, the desired power. It may be generally the value is taken as 0.84 for 80% power. This Z alpha by 2, it is the desired statistical significance, which is the value of Z alpha by 2 is 1.96 for 5% level. And this P1 minus P2, this is the effect size, which is the difference in proportion. So so we are noting down all the questions. Don't worry, we will answer the questions at the end. I'm just not responding to the question. Let me complete this and then we will discuss each of the questions. So this is the one. And then if you have got odds ratio, and you don't have the one of the proportion, then this is the formula for calculating the odds ratio from proportion. Like P2, 1 minus P2 multiplied, and then again in the numerator, you will take the multiplication of P2 and 1 minus P1, and in denominator, you will take P1, 1 minus P2 as a denominator. So this, all these two ratios, it represents the odds ratio. So if you have got one value and the one proportion, you can calculate the other. Ideally, these are not needed. Mind it, all the formulas, you don't need to remember it, because it is there. That background calculation is there in the statulator, but we are just giving it in case if you want to calculate it, or somebody asks you that what is the behind the scene formula which is running, then you should be knowing it. Otherwise, you don't need to calculate anything using these formula. This is again the same. So how to get the average P? So average P is the, again, what is the average P? P, I am talking of proportion of exposure in the cases and in the control. Okay, so P is the this is the proportion in the of the exposure. What is the exposure proportion in the cases and in the control? So if you have to take the average one, then you take the P cases plus P control divided by 2, and this is the same formula which you have seen. So you remember this one. This looks simpler than this. So remember that, but you, again, I am emphasizing it many times that you need not to calculate it. Just for background information, I am telling you. So now let's do it in the statulator. So in this case, for comparing two proportion, what do I need? I need the expected proportion of exposure. So remember, we started with the cases and we started with the control. And I have to see the exposure in the control and exposure in the cases. So I need exposure, expected proportion of exposure in or risk factor in the control group. And this group 2 is actually the cases. Group 1 and group 2, because if you see the statulator, it talks about the reference and then the experimental. So again, the reference will be your control and the other group will be your cases. And then desired power, we usually keep it at 80%. Level of significance, by mistake, it is written as 95. It is 5% actually. So now, again, the other things, like if you want to do a one-sided hypothesis, or if you want to change the group size, means the ratio of control and cases. If you have if you want to put some design effect, if you want to adjust for response rate or for continuity correction, like we did it in the first session. So all these are optional to you, but the first 4 things, like the desired power, the significance level, and the 2 proportion or the odds ratio, whatever. You can have 2 proportion, we will see in the formula, or you can have 1 proportion and the second odds ratio. So that is needed. So now let's do this calculation. So I will be showing you the calculations on following examples. So this first example is determinants of diabetic retinopathy in Southwest Ethiopia, a facility-based case control study. So in this case, objective is to identify determinants of diabetic retinopathy in Jimma University Medical Center in Southwest Ethiopia, and sampling unit is patients. So now in this case, please type in the chat box which is the outcome and which is the exposure. So outcome is diabetic retinopathy. Yes, it is right. And exposure we don't know because it is writing determinant. So I don't know. I'll have to see, yes, which determinants. There may be many determinants. So let's see which determinants this author is taking in the calculation of sample size. And the questions which was asked also, that which odds ratio or which this thing to be taken. So in that case, first see this. This is the sample size and sampling technique. So sample size was determined using, I'm focusing on this. I'm not seeing which formula or which thing they have used, but they have again said this thing. They have taken high baseline diastolic blood pressure. That was taken as a main exposure variable, as it gave the maximum sample size compared to the other exposure variable. So if you have got more than one exposure, like in this case, that for diabetic retinopathy, that person may have more than one exposure, maybe the age, hypertension, or some other exposure. In that case, you should take that exposure which is giving the highest number of samples, because if you calculate with the highest sample, then the other hypothesis will be again tested. So if you have got more than one exposure, then the exposure which is giving the highest sample size, you should take that exposure as a calculation of sample size. In this case, since the diastolic blood pressure was giving the highest sample size, or you can see the lowest odds ratio, because lowest the odds ratio, higher will be the sample size. So in that case, the odds ratio he has taken. Now let's see what are the inputs in this case. So the level of significance is 5%, the power is 80%. The ratio this author has taken as a 2:1, means one control and for one control, one cases and for one cases, two control. 9.47 expected prevalence of high baseline diastolic blood pressure among patients free of diabetic retinopathy. So these will be the control. So the exposure of this risk factor is 9.47% in case of control, and it is 21.1%. And that author is saying that is the expected one in the high baseline diastolic blood pressure among the cases. Now he has calculated 106 case and 212 control. Now let's see what is our sample size which is coming. So it is 106 and 212. So now I'll go to the statulator. So statulator, if you type in the Google that statulator, and if you click on the sample size, you can see that it is the comparison of, I have to use comparison of two proportion. Why? Because there are two proportions, a proportion of exposure in the control group and proportion of exposed in the cases. So these are the input values. So this is the expected outcome proportion in the reference group. Now don't confuse this word outcome here. Why? Because outcome in this case, for a case, see, what we say that like in this case, statulator is a calculator, or it's a statistical calculator. So he will take that outcome. He doesn't know that it's you who will have to say that outcome in this case is exposure. Why? Don't think in that context of exposure and outcome, because it is the expected outcome proportion in the reference group. So your reference group is the control group here. So you have to, outcome is the diastolic blood pressure, means exposure is the outcome here. Because in case control, what you do, you start with the cases and you have a control and you see the exposure proportion. So it is basically the proportion of risk factor in case of a control group. And this is the proportion of risk factor in the test group. Do you get it? Don't get confused with the term outcome here. This outcome will change in context of a type of study. In case of a case control study, what you are doing? You are measuring exposure. So it's the exposure proportion in cases and exposure proportion in the control. Because if you take diabetic cases as exposure, it will be 100%. Expected outcome proportion in the test group will be what? All the cases will have that outcome. So it cannot be. So don't get confused by the word outcome here. Outcome in case of a case control study will be the exposure, not for hypothesis, but for calculation in the statulator. So here what it is the ideally what he should have done, he should have written outcome, expected outcome proportion oblique expected exposure pattern in the reference group. That is missing from this text That's why it is leading to confusion. Otherwise, what is meant by this, that it is the exposure proportion in the control group. So what was the exposure pattern? If I want to see, it was 9.7. So we can see it was 9.7, I think 21. So what I'll do, it will be 0.09 here. And if you see so in this second case, you can see either you can have a second proportion, or if you click this measure of association, and if you see this drop down, then you can have this difference in proportion, you can have relative risk, or you can have odds ratio. Relative risk is there. We will use this option when we'll do the sample size calculation for odds ratio, because there also it is the same formula which is we use. The only thing that we will use relative risk instead of a odds ratio. So here we will use the difference of proportion because we have this difference of proportion. So not the difference, we have this thing, measure of association. So this 21%. So I will put it as 0.21. Okay. Now I'm not doing any adjustment, and you can see here, if you see the option, it is set at 80% level of significance, 5%, two side. But again, if you remember, the group sizes were in 2:1. So I will change this group sizes. So it will be 2:1, update, and this calculate. So if you see this is the 152, but again, it has taken equal group sizes. So I'll go here and I will update it once again. So you can see the required number of sample size, the cases is 125. So 125 is the total number of sample, and if you can take the control, so it is the 250. So total sample size will be the 375. And the person, he has calculated it as 106. But again, in this case, this tabulator always takes into that continuity correction into account. And continuity correction is what? That normal distribution, because we are doing the binomial distribution here, presence or absence. So whenever we use this binomial distribution, we should apply continuity correction, and the continuity correction gives a little extra sample size. That's why this difference of 106 and 125 is there. So otherwise, or everything else is same. So this is how we calculate the sample size if you have got two proportion. Now we'll see another example when you have got one proportion and one. So this was the one two-sided adjustment for continuity correction, 10%, 21%. I have written all these inputs in a tabular format so that it is easy for you to enter this into the tabulator. Now the second example is a case control study about the association between the hepatitis C infection and oral lichen planus. In this case, what is the exposure and what is the outcome? So outcome is your lichen planus and exposure is the hepatitis C infection. So you know this. So now this is the sample size formula. So the prevalence of hepatitis C in healthy population is 1%. So many a times you don't know actually what will be, because once you are calculating the sample size, if you don't know the exposure in the control from a previous literature, then you can take the prevalence, or you can assume the prevalence of that exposure as a community prevalence in your control, because you assume that you will take healthy control. So it is 1% in this case. The odds ratio from the previous study is 8.3. And the power in this case, it is 90%. And the level of significance, it is the 5%. And in this case, the alternate hypothesis is two-sided, group sizes are equal. Just read this 95% level of significance as 5% and adjust for continuity correction. So if I have to, now I'm taking one as a proportion and second in the form of a odds ratio. So I have to calculate with 1% and 8.3% of odds ratio. So in that case, I'll go to the, so in this case, I'll reset this. So again, this is first is the 1%. 1% will be 0.01. So I have made it like this is your 0.01. And the second is a measure of association, because the second is, in this case, the difference in proportion, I will use the odds ratio, because odds ratio in this case it is 8.3. So I'll type here 8.3 and I'll calculate. So the required sample size is 170. So this 170, we have taken this sample and the equal number of control. This will be the required sample size for this calculation if we are using this odds ratio. Now the third example is relationship between the childhood sexual abuse and psychiatric disorder. In this case, what is the exposure and what is the outcome? Please write in the chat box. So the case here is a psychiatric disorder. Yes. And exposure is the childhood sexual abuse. You are right. So again, in the outcome, what will I write? So I have to write the prevalence or the proportion of childhood sexual disease, sexual abuse in psychiatric disorder in the adulthood. So I will be taking the adult who are having any psychiatric disorder, and then I'll take control, and then I'll see how many of them had undergone a childhood sexual abuse, right? So that outcome, which I was discussing in the statulator here, I have to, although outcome, case and exposure, this is okay for hypothesis. But when you are giving it as an input, in that case, read, in case of a case control study, read that sentence as a proportion of outcome or a risk factor or exposure, not proportion of exposure in the cases and proportion of exposed in the control. So this is the one, 35%, 20%. So you can do this. So all of you are requested, please do this and then type in the chat box how much sample size you got. So expected prevalence of childhood sexual abuse in psychiatric disorder in people with psychiatric disorder is 35%, and expected prevalence of childhood sexual abuse in adult without psychiatric disorder is 20%. So those of you who have got two systems, you can do this. Maybe desired power is 80% and level of significance is 5%. Group sizes are equal, and adjusted for it is adjusted for continuity correction. So remember, it is the 35% and 20%. Okay, so 149 each. So let me check. So I'll again reset this. So with the two proportion, I'll use this 0.35. And here it is 20%. So no, this is in the reference group. You have to see in the reference. In the reference group, it was 0.20. And in this thing, it was 0.35. And there was no adjustment. So it is 149. So yes, you are right. All of you are right. In this case, it is 149 without having any assumption. I'm not taking into account of any assumptions now. So yes. So now let's see. So yes, some few more examples. So this is one example where there was an intervention actually. You want to see the effect of an improved water supply on risk of diarrhea. So what is the exposure here? All of you please type, what is the exposure here? And what is the outcome? Water supply. So improved water supply will not be exposure. Here it will be the not improved water supply will be the exposure, and outcome will be the risk of diarrhea. So you have to take, like, if the improved water supply is 60%, then you have to take 40% because you will take the risk. So risk is people who were not having access to the improved water supply. Did you get it? If the exposure here or the intervention is a positive one, then you have to take the left out as a risk factor, because risk factor will be the proportion which has not got the improved water supply. That's why there is a diarrhea. Okay, so that's why I have taken this proportion of poor water supply. In non-diarrheal cases was 70%, and the odds of poor water supply among diarrheal cases, it was 1.5. In this case, the power was 90%. It is a two-sided hypothesis, 5% level of significance. Anticipated response rate was 75%, and the adjusted continuity it was adjusted for continuity correction. So now you do this and tell me what is the value. So remember, power, it is more, 90%, and response rate is also 75%. So you have to do these two adjustments also, response rate and increase in power and reduction in, the response rate into account. So once you, all of you, please do it, and then I will do it. Or me, I also can do it simultaneously. Why to waste time? So I'll reset this. In the first case, it is 70%. So it will be 0.70. And in this case, it is 1.5. So I will take measure of association because it is saying the odds ratio. So odds ratio, it is 1.5 is the odds ratio. And then I have to increase the power also. So I'll increase the power to 90. And this I have done it to 0.9. Group sizes are equal. And then adjustment, I'll do response rate. So response rate was 75%. 75%. So now update, and then I have to calculate. So, and after calculating, do see the description. So it is writing that 70% of the subject in the reference population have the factor of interest and expected response rate of 75%. After applying the continuity correction, the study would require 688 in each group, a total sample size of 1376 to achieve a power of 80%. Again, it is 80%, so you can increase at many times. It comes back again to 0.9. So you can see now, again calculate, so it will so now it has taken that 90%. So 913. So you can see with 1.5, the number of cases has increased to 913. That's what we were discussing. If the odds ratio is less, because 1.5 is a less odds ratio, so you need a very large sample size. 2, and that we remember that with 2 and with 1.5, just with the decrease of 0.5 odds ratio, the sample size requirement increased to 3 times the cases. So yes, you are right. You have calculated rightly. And then again, the second question, study of association between vitamin A deficiency and risk of diarrhea or morbidity. So which is the exposure and which is the case here? So case is, again, the diarrhea is the case and vitamin A deficiency is the exposure. Yes, you're right. And this is again 10%. Population suffer from low vitamin. Again, you see, we will not take how much is the coverage of vitamin A, because that will be good. The exposure you have to take that low vitamin or no vitamin. So that will be 10, that is 10%. The odds ratio is 3, power is 90%. And in this case, control to case ratio is 4:1. So similarly, you can do this and you can check for that. So in this case, now let's discuss one very important concept. When you have got a fixed number of cases, like whenever, just see this example. So you know that there is just read this example. A study of the impact of a hygiene education program on the risk of diarrhea morbidity was planned, and the investigator is constrained by the need to complete the study in 6 months. So the investigator had this pressure to complete this study, or maybe many times it happens in thesis or many projects also that you have to complete it in a short span of time. And during that period, or maybe if it is a record based, you have got limited number of cases. You cannot expand the number of cases. Why? Because it is a record based. In this case, the investigator is expecting that in 6 months period, he will not get more than 180 cases of diarrhea. But the required sample size, if in this case, if he has used the sample size with this assumption like 60% not adequate to diarrhea prevention program with 2 odds ratio, 95% of power, 5% of level of significance, 1:1 case control ratio. So in this case, if he calculates the sample size, so in this case, all of you please calculate. I am also calculating simultaneously. Power is 95, 5, 60% and 2 is the odds ratio. So I'll go back to the window tab, and then this is I will reset this. And with this, yes. So now you can see that 70% was the exposure in the control population. So it is 0.70, and the odds ratio, the measure of association, was 1.5. So this odds, I have selected this odds ratio. I have clicked this as 1. No, it was 2, I guess. Yes, it was 2. And then adjustment was done for, and this was also 60%. It was not 0.70. Yes. Let me check it once. Yes, it was 60% and 2 odds ratio. So it is 0.60, 2 odds ratio. And then again, I have to increase the power to 95. So maybe 80% also you can do that, but that investigator did it with 95. So I've increased the power to 0.95. And then these two things are same. And then adjustment he did for the, let me see any other assumptions are there or not. So no other assumptions are there. Even adjustment, no, he did not adjust. Only for power he did the adjustment. So if I calculate this, then the calculated sample size is 163. But again, you will see that in this case, the power is 80%. So it has not updated. By default, it is taking the 80%. So I have increased this and I have updated this. So it is 261 now. So with this 261, but what was the person problem? That person was thinking that he can only take 160 case because that is the proportion of cases with which he will receive. But the calculated sample size is 261. Then in that case, what he could have done? So what he did, in such cases when you have restriction, in this case, you know that the person is knowing that he will have only 180 cases of diarrhea. So if he is planning to conduct a case control study, then he can increase his power by taking more number of control. And how to count for that? Let's see this. So you need to consider the case control ratio in such situations. And then you can, if you take more number of cases, more number of controls, then you can adjust for this reduction in sample size for the cases. Are you getting this? If you are bound that you cannot increase the number of cases, either you are anticipating that in this many months you will not get more number of cases, or you are thinking that with the record you have got only those number of cases. In that case, if you increase the number of controls, because there is an option you can increase the number of controls. Cases you cannot increase because that is not your hand, but controls you can increase. But how many controls you should take, that we have to decide based on this formula, and you need to calculate the ratio of case to control in such situation. So in that, normally the case to control ratio is 1:1, But when the available cases is small or investigator wants to finish the study in a short period of time, then by recruiting the large number of case, the the investigator may reduce the number of case. So in this case, the required number of cases is, the formula is C plus 1 divided by 2C multiplied by N, where C is the control and N is the number of cases. So this reduces the number of cases needed by 50%, but it doesn't reduce more than 50%. And that's why we call it, if you recruit 4 controls for one case, beyond increasing the number of control will yield no result. That's why you should now not have more than 4 controls per case. That is the maximum. So this is the formula. So if you see, if your number of control is 1, the adjustment factor is 1. So if your number of control is 2, then it is 2 plus 1 divided by, you can see it is the 2C. Similarly, these are the multiple adjustment factor. So you have to multiply this to calculate to the calculated number of case, and that will reduce the number of case. So if you have got 3 controls, then you can reduce the number of cases by 0.67. If you have got 4 controls, then you can reduce the number of controls by 0.62. But beyond that, you will see that it doesn't lead to any more gain. So that's why in this case, again, this is the same for 6, 7, and 8. And you can see that the multiplication factor is almost the same. 0.58, 0.56, 0.56, and 0.55. So maximum is your 4 control per case. So the same, this is what I did. The required calculated sample size was 261. But the investigator knows that he can have only 180 cases. So what is it is the multiplication factor of 0.67, which we got. So this 0.67 match with this. You can see this. So that person needed 3 control per cases. So if that person or the investigator takes 3 times number of control, then he can adjust for the less number of cases. Did you get this? If you have got this limitation of you cannot increase the number of cases, then by taking more control, you can adjust for your sample, your power and significance. But how much control? It is not arbitrary that I wish to take 1 control, 1:1 or 1:2, 1:3 or 1:4. No, it is based on a multiplication factor, and that multiplication factor is decided by this, that you multiply your number of cases with these fractions depending on the number of control. So in this case, this fraction is what? This fraction is the required cases, the available cases by required cases. So this is the fraction, adjustment factor. Available cases divided by cases which you have calculated from sample size. And that's why we have taken in 1:3. So now this we discussed for the binary outcome, presence or absence, because both the exposure and outcome is a binary. I will discuss only one situation by giving only one example, because I said that it is not a very common practice to use this exposure as a continuous variable in calculation of a sample size, but you will find few articles where they have used this continuous exposure. And that we do just to see the dose response relationship. If the exposure is like you are measuring some carbon monoxide level in the blood, and if you think that, if you convert into the binary, then that meaning is lost. So if you dichotomize the continuous variable where there is a clear-cut dose response relationship, in that case, you are losing the data. So that case, you should calculate the sample size based on the mean. So because you are thinking that risk is increasing with this increasing exposure, so it is not a good practice to make a category. And again, because we know that this dichotomization will obscure the effect, and it will result in a overestimate of number of sample size. So let us see with this example. So this is the again same sample size formula, which we have used for proportion. It is the sample size in each group. R plus 1 by R is the ratio of cases to control. This is the pool standard deviation. There we have used the proportion pool, that is the average proportion in the two group, and then this Z alpha and Z beta are same, and this D is the mean difference between the expected cases and control. So with this is one example. You should have the mean of exposure in the control group. You should have the mean of exposure in the cases group, and you should have a standard deviation, that is a pool standard deviation with the desired power. And these adjustment could be, it's optional, but must be is these are the things. So this is the one example which we could find out, that relationship between this shoulder impingement syndrome and thoracic posture. So in this case, the author wanted to investigate whether there is a relationship between the shoulder impingement syndrome and thoracic posture. So the outcome in this case was the shoulder impingement syndrome, and the thoracic posture was the exposure which he measured as a Cobb's angle. I think Cobb's angle is an angle which is measured on the X-ray, and it is a continuous measurement. So he has given this input as, I have already told what is the exposure and what is the outcome here. So he has written that he wanted to detect a 5-degree difference in the modified Cobb's angle between the group with a standard deviation of 10 degrees. And he calculated it as a 34 participants in each group with a 5% level of significance and 80% of power. So let's do this calculation. So it is the difference standard deviation is 10 degree and the 5-degree difference I have to use. So I will again reset this. And in this case, I will use the formula of mean. So if you click this option, you can see there is a compare the two independent means. So here I have used this. And in this case, if you see the input, you can see here that I have to use the expected difference between the mean, because here the difference of the mean is 5 degree and standard deviation is the 10. And he has not done any adjustment. So if you calculate the sample size, so you can see it is the 63. So assuming a pool standard deviation of 10 units, the study would assume a 63, so total 126. And the difference he wants to calculate. So that was the calculated sample size which we got. So now this was the one we have done this. Now do one example you need to practice. So you want to see the association between the birth weight and diabetes in adulthood. So birth weight, that is the child birth weight, and the onset of diabetes in adulthood. So what is the exposure here and what is the outcome? Yes, please type. Yes, exposure is the birth weight and outcome is the adult diabetes in adulthood. So in this case, the expected difference in the diabetic and non-diabetic adult, that is the birth weight. It is the 250 gram and the pool standard deviation is 1000 gram. Now calculate the sample size with the 80% of power and 5% of level of significance. Other adjustments are not, we have not put another assumption. These are the only two assumptions with 80% and 5% and 250. So do calculate this. I'm also doing it simultaneously. So expected difference is 250. So I reset this. Mine is taking longer. So 250 is the expected difference between the two group and 1000 is the standard deviation, pool standard deviation. If you calculate, yes, you are right, it's 252 in each group. So that was the major concepts which are involved in the calculation of sample size of a case control study. The case control study which we have discussed, that is largely we have not talked of a matched case control study. A matched case control study, the calculation of sample size, it is done a little bit differently, where we take the this R, we call it as a this correlation, and which is the phi and Kramer V correlation which we take. And because matching what we do, because if you don't match it, there is a reduction in the loss of power due to the confounding variables. The calculation of sample size in case of a matched case control study, it is done using a different formula, but it is very much similar to the unmatched case control study. That's why we have tried seeing it, and almost all the author, they suggest, especially the WHO, it suggests that you should calculate the sample size for a unmatched one, and you can use the same sample size for a matched study also, because where they are very near to each other. Because most of the time that correlation, or the phi or Kramer V correlation coefficient, which is needed for the calculation of sample size for a matched case control study, it is not available. So that's why it is better that you use the calculation of formula, and what we have shown you, that is for unmatched case control. So you can use a similar concept for a matched case control study also. Now a few more concept on confounding. So there are many, like you can match, you can do the age matching, you can do the gender matching, but in spite of the matching, there are many unknown confounders. In that case, if you are anticipating some unknown confounders, you can increase your sample size by 25%. So this is not a hard and fast rule, but again, that WHO document, which is the major basis for this presentation, that suggests that you should increase the sample size by 25% for any unknown confounder if you are anticipating it in spite of matching it. So now let's see some common things in the case control study. So this is one of the article where that our author has seen the association between the colorectal cancer and the prior antibiotic prescription use, a case control study. So you can see here they have taken all the cases. So I'm just reading only the highlighted portion. So they took all the 12-month clinical record cases, and the cases were matched on the year of birth within 2 years to increase the probability of identifying the controls, and they took 4 controls for each case. So they did this. I'm not going into detail of this, and at the last you will see here the final what they have selected. It is they have selected 35,214 cases and 60,348 control. So here the case control ratio was 1.7. So, but they have not calculated it. They have taken it in a record-based manner. So similar thing you can do. If you are planning a case control study entirely record-based, then whatever is available, you can calculate it. You can see the eligibility criteria of both the cases and control. You can run the analysis. And then at the last, you can say that in your study, the ratio of the case and control, it was 1.7, because you are not recruiting, right? That planned 1:2, 1:3, 1:4, that you can do only when you are planning to recruit control from community or from hospital. But if you are entirely planning your study based on records, then, and if there is a limitation, then again, whatever ratio it is available to you with the cases and control, you can say that. But with such a high number of cases and control, definitely the power of your study is very huge. So in that case, it is not always needed also. So in this case also, there was an article, infertility as a risk factor for breast cancer, and it was a hospital-based case control study. And you can see they have started with 1,410 cases and 1,410 controls, but they have taken only 1,177 cases and 1,204 controls, because that were the eligibility criteria. So now I think I will not discuss these things. Let's see the questions. So or should I discuss this? So let's discuss this one. What is the time? Okay, so before I discuss these, I think let's run the poll and so that you can also answer. So this is the question. So what is the purpose of a control group in a case control study? So these are the two options. So the correct answer is to provide the information on the exposure distribution. And it is 75% of you have responded it correctly. Now see the next poll. So this is a question. Is not having disease or outcome is sufficient to define a control? Yes or no? So the answer is no. Only not having the disease is not the sufficient criteria to define a control. So you want to see whether the use of oral contraceptive pill is associated with breast cancer or women who do not have a breast cancer. Is this information is enough to consider her as a control for this study? Again, very much similar to the previous one. Now the next question. So you conducted a case control study to know the risk factors of aortic stenosis, which is an appropriate control group. Catheterized patients with no aortic stenosis, but with another type. Catheterized patient with no AS and no other type of valvular disease. Surgical patients whose reason for surgery was not known. So in this case, all can be controlled because this is a study which has been done. Actually, the author has taken all the three controls, but the best control will be the first one, catheterized patient with no AS but with another type of valvular disease. But again, he took all the three controls and he has shown the odds ratio with respect to all the three type of control. So you can do, like we will share few references also. You can see that in classically case control study, they have more than one control, where they take one control from the hospital, one control from the community, maybe the two controls from the community, and then they show the odds ratio with respect to each of the control. So that's one way of doing a case control study. Now another poll. I think it's done. So with this, I think we would take few questions. So what was the question? Venkatesh, can you show us the... So that one question was for a study, the odds ratio, which factor we should take. So that I have responded. You should take that odds ratio. If there are 2-3 risk factor, then the lowest odds ratio will give you the highest sample size. So that will satisfy the other odds ratio also. So that's the criteria. Okay. So what was another question? Vibha, what was the Bhavna? I don't... how can I see the questions?
They raised the hand.
Few of you have raised your hand, while Vibha and Bhavna.
Good afternoon, ma'am.
Good afternoon.
Yeah, wonderful session. Learned a lot as usual. I just wanted to know, ma'am, the last presentation we attended in January, I got a link on my mail for the reference material, but when I clicked on it, it was showing error. So I just wanted to clarify if we have to log in on the Merit India website to go for the materials, or it will be sent by email. Thank you.
You have to log in.
You have to log in again.
Materials
Okay,
are-
ma'am. Right.
Materials are there, so you will get it.
Yeah. Thank you so much. Thank you.
Welcome. Vibha, you also raised your hand. Any query? Okay. So if there are no other, I think in between also participants pasted few questions. So if there are, I think one question I can see, when to use match control study or unmatched study. Okay, so that is a separate session for epidemiology. That is more of a epidemiological issue, when to do that. But definitely matching is a relatively difficult concept. And that the analysis of a matched case control is also, we do it like a survival analysis. When we take that person years or the person exposed for how many days or how many months into account. So we do it as that Cox proportional hazard or survival analysis type. So that's why we will again have a session on the epidemiological concepts on these case control, the matched as well as unmatched. So that's why maybe it is not the right time to discuss those concepts. But again, most of the case control study which we do, that is an unmatched type. Don't think that, if you just do the matching of age and gender, then it becomes a matched case control. No, that you are just doing taking a matched control, but a matched case control study, we take the time also into account. Okay, that Manisha, you also raised your hand.
Yes, ma'am. I wanted to ask that how to decide on the case control ratio. That portion was not clear to me.
Okay, so that
How to
ratio is
decide?
again depends on the adjustment factor. So how do you do it? If you can see the required number of sample size you have calculated using a formula, right? So that if I go back to that slide, which I have shown you that that author required 261 sample and he was having only, I think, 160. Yes. So the author was calculated sample size was 261, but he's having only 180. Okay. So in that case, the adjustment factor, you have to divide this ideal ratio, ideal number of sample size with the available. That will give you adjustment factor. And then you refer to this table. So this table you can see here. If adjustment factor of 0.67 says that you should take 3 controls. So if you take 3 control, you can reduce the number of sample size by 67%. Did you get it?
Okay, ma'am.
That sample size is only for cases. Whatever I'm discussing, that is of cases. Like, to put it in another way, if you take 4 control for one case, you can reduce the number of cases by 62%. If you take 5 controls for one case, you can reduce the number of cases by 60%. Okay. But 260%. I mean, not by, you can reduce it to 60%. That's why the adjustment factor. These fractions you calculate by the what is the available divided by what is the required. Did
Okay, ma'am. Thank you, ma'am. Thank you, ma'am.
Okay, welcome. Anybody else who is having any other problem or query? Then you can note it down. Maybe when we'll have the case control, when we'll have the sample size calculation for cohort, then also we can, if you post these questions on the mail, then we may try to answer over that also, or we can send you references also. So this is for quasi experimental. That is again a separate session. For experimental, that will be in April. So in March, we'll discuss for cohort.
আমি করে দেবো।
So,
Okay, so shall we finish, Venkatesh?
Yes, ma'am. We can conclude with the session. Thank you so much, ma'am, for the wonderful
Thank
session.
you so much. We'll meet again in March. Okay, see you then. Bye to all.
Thank you, ma'am. Team Clarinet, please close the session.